Hello everybody, welcome to the EM Code. This is Dr. Vajiha, emergency physician by occupation. Join my quest in asking right questions from right people to the right answers. The guest for today is Dr. Sajjad Pathan. He's an emergency physician consultant working in the UK. He's also founder and director of CMED India. It's a pleasure to have you, Dr. Sajjad Pathan. Welcome to the EM Code.
Hello, all of you. Before I begin, I want to pass on my condolences to those people who have lost their loved ones in these difficult times. I want to tell you all medical workforce people to stay strong. You are doing your best and you should feel proud about it, that the country needs you at this time and you're standing strong. Be supportive to each other because they are the ones who are backing you up. Back up your colleagues and have short breaks in between. Take care of your health first. If you are healthy, people in India will be healthy. Thank you for inviting me today to talk about few things which I feel is essential to the medical team in India considering the situation.
Thank you for your words of encouragement and wisdom. And my question to you would be, what are your concerns as an emergency physician in this pandemic? Where do you think things have gone wrong? And what interventions can be done timely to control things in the future?
I don't know how many of you have gone through the ICMR guidance. What concerns me at this point of time is the lack of resources. The lack of resources because we have been too generous in doing all sorts of investigations when it was not recommended or required. You have the clinical skills to examine the patient and make a decision what next to be done. A CT scan was never a screening tool, but I see now and then that we are using CT scan as a diagnostic tool. Where are all our skills gone? Can we do simple basic news scoring, clinical examination, and making a decision based on the guidelines given by the ICMR? If you look at the ICMR guidelines, I will post it here for you guys to look at it. This is taken on 22nd April of this year, and it clearly classifies the conditions into mild, moderate, and severe. Mild patients are those patients who are having either no symptoms or milder symptoms. And then the recommendation is, guys, please discharge them home. They need not be admitted. They need home isolation. They need home care. They need to stay isolated, monitor their temperature and oxygen saturation at home, do deep breathing exercises, lie prone, do some yoga, hand hygiene, and indoor mask use. What can work is hydration, antipyretics, antitussives, and multivitamins. They need to seek medical attention if they feel they are having shortness of breath. The medical attention could be sought out by virtual clinics. Medical attention if they are short of breath or if they feel they are unable to cope and things are getting worse. They don't have to be screened with CRPs, CT chest, or D-dimers. What will happen if you keep on doing CRPs, D-dimers on everyone? You will come across several false positives and then you will try to work out why is the D-dimer high, and then you will further investigate these patients, bring them to hospital for investigation and expose them or others who are non-COVID people with COVID. Or you will provide them with unnecessary treatment including heparins and whatnot. So please do not over-investigate. A simple FBC as an initial screening is good enough after a RT-PCR. If they are short of breath, consider doing an arterial blood gas, a chest x-ray, and then make a clinical decision whether they need to be admitted or not. The ICMR has clearly given the guidance over here that what is classified as moderate disease. Moderate disease is those with respiratory rate greater than 24, saturating less than 93. Severe disease is those with respiratory rate greater than 30, saturating less than 90. These two classes of patients are to be admitted. Those with moderate to be admitted in ward, those with severe to be admitted in ICU. Now those to be admitted in ward again needs the same care. You do not need to give them unstudied care or off-label drugs. The ICMR says start them on steroids, awake proning encouraged, give oxygen as needed, and clinical monitoring with work of breathing, hemodynamic instability, change in oxygen requirement, and because they are admitted now, they will be immobile, so give them a prophylactic dose of heparin. Lab monitoring is written as CRP D-dimer if done to be monitored every 72 hours. Serial chest X-ray, nowhere it is mentioned as serial CTs. A CT scan is to be done only, which is in caps, if there is worsening. So this is the guidance given by the ICMR for moderate patients. And it doesn't mention Remdesivir or Tocilizumab or Favipiravir anywhere over here in mild and moderate. In severe diseases, again the same anti-inflammatory which is your steroids and heparin and supportive measures. Here they say you can do CRP and D-dimer every 48 hours. And you can discharge these patients as per after the clinical improvement.
Polypharmacy is becoming a range these days. What are the things physicians have to be mindful of before prescribing certain drugs, and what are the things they are supposed to, over a period of time, monitor? Also put light on the off-label drugs that are going on. How are we casually promoting microbial stewardship?
Let me start with ivermectin. If you go to CDC website and see where ivermectin is, whether it is recommended, they have clearly mentioned FDA has not reviewed data to support use of ivermectin in COVID-19 patients, either to treat or to prevent it. However, some initial research is underway. Taking a drug for an unapproved use can be dangerous, and this is true for ivermectin too. Ivermectin has been successfully used for filariasis and strongyloids, but there is no evidence to use it in COVID. That is why the ICMR mentioned may use. So make a rational judgment. At two places, the ICMR has written may do in mild disease, which is ivermectin, and I'll come to ivermectin later on. They have written ivermectin for 3 days, and they have written may do. These are the therapies based on low certainty of evidence. Or hydroxychloroquine for 4 days, or inhaled budesonide. Now, I have seen prescriptions with cefixime, coamoxiclav, azithromycin, doxycycline, ivermectin, hydroxychloroquine, dexamethasone. Why are we doing this? Why are we unnecessarily prescribing? There is no antimicrobial stewardship. You are giving rise to resistance. So please stop prescribing unnecessary antibiotics. Hydroxychloroquine and azithromycin is a deadly combination. It will affect the QTC, and the patient, if not dying with COVID, will die of the drug interaction leading to long QTs. Think about it. Off-label. That means the studies are underway and there is no clinical evidence available. Off-label Remdesivir should be considered in moderate patient only for moderate or severe patients if they have normal renal function, normal liver function, and if they are within 10 days of onset of symptoms. Otherwise, no. I will come to Remdesivir and ivermectin later on. They said Tocilizumab is a compassionate drug, can be used in severe disease. This is a monoclonal antibody which we can use if they are going into inflammatory response syndrome. But again, this is off the label. It has not been studied for that. Convalescent plasma. I see every day on WhatsApp and Twitter, plasma, please donate plasma. Plasma is off-label. Off-label. It has not shown to be efficacious. And what are you trying to do is put somebody else's blood product in your patients. So again, you see what we are trying to do, we should not be doing. And it is only recommended here in early moderate disease, not in severe disease, within 7 days.
The irrational use of steroids is gaining prevalence in the general public. How do we prevent this, and when are steroids actually indicated? Since you are here, let's discuss about the evidence-based articles that are present for the treatment of COVID-19. Also, how the doctors can legally protect themselves by following the guidelines.
One more thing I wanted to highlight with the ICMR thing is if you follow those guidelines, you are legally protected, because ICMR has said what is moderate, what is severe, what I'm supposed to do. You are legally protected, especially in those tricky cases where respiratory rate is 24, not 24, you can say about 20. If it's 20, it's less than 24. So that's mild disease. So think about it, go over the recommendation and see. Next, I will talk about the article published in New England Journal of Medicine, February 25, 2021. Dexamethasone in hospitalized patient with COVID-19. A very good article, a very good study. That's recovery trial. And it said use of dexamethasone will lower 28-day mortality among those who are receiving either mechanical ventilation or oxygen alone, but not among those receiving no oxygen or respiratory support. So is it correct for us to prescribe dexamethasone for patients who are isolating at home? No. So this is the evidence we have. I'll post a link for this article as well in the discussion below. Let us read about Favipiravir, which is an article published in Medical Journal of Armed Force India. This was published in 2020, and the authors are well-known authors. I've worked with Dr. Zarir Udwadia at Bridge Candy Hospital. Zarir Udwadia is a consultant pulmonologist and very intelligent in his field, and he has written down this article where it says that Favipiravir is effective as an antiviral in mild illnesses, but weigh the pros and cons and weigh the drug interaction again. Favipiravir is known to cause QT prolongation, and Favipiravir is known to give rise to or precipitate an attack of gout.
Since we are already on evidence-based medicine, please share articles on the famous antivirals, when they are indicated, their adverse effects, and how do we appropriately choose a patient who requires a certain antiviral.
So the article says Favipiravir led to 28.7% faster viral clearance as compared to the normal standards of care. Treating clinicians judged 70% of patients in the Favipiravir limb to be clinically cured by day 4 versus 44% in the standard of care arm. However, the article doesn't publish a complete result which should show us the p-value, whether the results are significant. Secondly, the odds ratio and the confidence interval related to it. Thirdly, I would say there's no mention of number needed to treat or number needed to harm. So use with caution in mild conditions because it is being prescribed off-label. Be wary of the fact that Favipiravir can induce QT prolongation, can cause hyperuricemia, and can lead to teratogenicity. So if you're prescribing to females, do a urine pregnancy test before writing it down, and also weigh the cost of the medication, whether the patient will be able to afford it versus. So have a holistic approach before writing Favipiravir down for your mild conditions. Next, we'll talk about the Remdesivir. Again, Remdesivir should not be used for all. It is being used off-label. It's very, very expensive and a lot of black marketing going on, so don't promote it. And see to it that you prescribe only when it's indicated. So the indications are very clear. What the Department of Health in the UK has done is last year in November, they issued a guidance for us to prescribe Remdesivir when it has to be prescribed. So it clearly shows a pathway. I'll put this article as well down for you to go over it. So when the patient presents to the hospital, do not initiate treatment if they are unlikely to survive. or if they are having symptoms greater than 10 days. This is the first thing. If you admit them, next thing to do would be whether the patient needs oxygen or not. If the patient does not need oxygen and his 4C mortality score is low or very, very high, then do not use it. If 4T mortality score is intermediate or high and the patient needs oxygen, then you start Remdesivir, and Remdesivir should be started in consultation with the team. So it's based on your 4C score. It needs to be daily assessed whether the patient needs to be continued on. I think maximum is for 5 days it has to be given, and it needs to be stopped if by 72 hours you don't see any improvement. And the moment you start seeing improvement, again it needs to be stopped. You don't have to give it all the way five days. So this algorithm is really useful. From this, I think the take home points is the 4C score before prescribing Remdesivir, and should not be initiated to patients who are unlikely to survive or those greater than 10 days of symptoms. So this is the take home point.
We cannot not talk about the elephant in the room, the vaccine. Who should take it? Who should not? Which one to take it? What are the side effects of each of the vaccines that have been launched so far? Please put some light on them.
We have a green book guidance for looking at the vaccine details, and it talks about AstraZeneca, Pfizer and Moderna vaccine. Right now in India we have AstraZeneca and the Bharat Biotech one, and I think we are also going to start the Russian vaccine soon. So it doesn't talk about the Russian vaccine, but from AstraZeneca purposes, I would say there are few concerns whether the vaccines are safe, whether the vaccine can be given in pregnancy, whether the vaccine can be given when the patient is lactating, and vaccine whether it can be used in children. Vaccines for pregnant ladies and in children, the studies are going on. However, considering the pros versus cons, benefits versus risk, I think it is safe based on our previous experiences with the inactivated vaccine. So in pregnancy, it is not mentioned as a contraindication. It has said that if she is pregnant, it is said that if she is pregnant, it is safe for her and the child to take the vaccine. However, the studies are still going on. In terms of the side effects and the effectiveness of AstraZeneca, so here they said a single dose of either the Pfizer or AstraZeneca has shown to provide 60% protection against symptomatic disease. Vaccinated cases are also 40% less likely to require hospital admission. So vaccination has potential to reduce transmission, and this was shown by the Scottish study as well. It is safe. Side effects are very, very few. People are worried about the side effect profile, which is one of the major things people are concerned about, is the thromboembolic event. In the UK, 5 out of a million cases were reported. I don't know about the outcome of them, but the thrombosis was more common in younger people than the older people, and it's 5 out of a million case. So considering the benefits of vaccination will outweigh this small risk for the adults age 30 and over, I think it is advisable for getting vaccinated, because we need to stay calm and we need to support each other. Otherwise, if we break down, the whole system will break down and the whole system will crumble. So stay safe. If you haven't vaccinated, get vaccinated. Tell your family members to get vaccinated. Tell everybody who comes to you to get vaccinated. Just before I end, I want to thank you guys for listening to me. Thanks to Wajiha Musharraf for having me over here. And please get in touch with me if you need any further guidance. Stay strong, support each other. There will be tense moments, there will be overwhelming moments, patients losing their control, patients getting angry, coming to threaten you or to hit you. You need to stay professional.
Thank you so much, Dr. Sajjad Pathan. Thank you so much for your time and effort in explaining in detail about the ICMR guidelines. It's a pleasure to have you here. We cannot wait to have another session with you. Thank you so much.